Okay, good morning, everybody. As usual, we will give it just about a minute before we can get time for everybody to join us. Hope everybody is having a good week. A couple things, as usual, we will be providing CME, and we have the exciting presentation, and I'll talk more about Drs. Villarino and Studemeister in just a few minutes. Wanted to also share with you our upcoming presentations, upcoming grand rounds. We have a great talk coming up next week with thrombosis in COVID-19 with Dr. Carolyn Berube and Marie Hollenhorst. This grand rounds will also start off sharing some of our education awards in the Department of Medicine as well. So we'll take a few minutes at the beginning to share the winners of our education awards. The following week will be ethics in COVID-19 with Dr. Magnus. And then following week, we'll be talking about the New York COVID surge with Dr. Jeremy Bretler, who was actually known for one of the doctors coming up with the idea of combining two people to be ventilated by one ventilator. Really interesting talks ahead. With that being said, we do have one update with Dr. Song. Some updates. As many of you know, has been in charge of occupational health, and we've had quite a few changes in that regard. So Song would like to provide some updates. I'll turn it over to you, and I'll stop sharing so you can start sharing your slides as well. As always, thanks for everybody for joining. Thank you to all our panelists who are going to be sitting in the background and answering all your questions as they pop up, and we'll try to spend a lot of time today to get to Q&A as well.
All right, good morning. Good to be here. I just have a couple short updates to share in the occupational health arena. In light of the recent loosening of shelter in place and then updated guidelines from the national, state, county, and even university authorities, we've examined and then approved some new expanded testing criteria for asymptomatic healthcare workers, and I just thought we'd share them. The recommendations don't fully follow a single source because frankly, they're all a little bit different, but it's a consensus judgment of our infection control team, our occupational health folks, and School of Medicine clinical leaders as well. So, that's amazing. My thing froze. There we go. All right. So we're going to be testing new employees, all new employees. We're going to require that, including new residents before they start working. But our asymptomatic expansion is going to be as follows. We're recommending anyone who attends a mass gathering of more than 100 people to test themselves. Healthcare workers who frequently use public transportation are encouraged to be tested. Healthcare workers who travel by airplane from anywhere, when they come back to be tested within 2 to 5 days, but not quarantining routine domestic travel. Healthcare workers who travel out of the area, but not by mass transit or airplane, we are not recommending any specific testing for, unless of course they've had a known exposure. Healthcare workers who travel internationally, we're recommending quarantining for 7 days, as opposed to the 14 days of the CDC, but to test and have a negative test prior to returning to work. The group we are not recommending testing, so all healthcare workers, we strongly encouraged to test, and more than half did once, but based on the results, we are not recommending at this time routine periodic retesting. This is based on our own experience over the last 3 months monitoring our 15,000 healthcare workers. We've had an incidence of asymptomatic positivity of about 0.3%, but none of those persons have posed a detectable risk to their peers or patients. In other words, we haven't had a healthcare worker illness or a patient illness whose only exposure was to an asymptomatic healthcare worker. So in an abundance of caution, when we find one, we send them home and wait till they're negative. But based on this experience, we're not recommending periodic retesting. We're monitoring the environment and the employees very closely, and we'll change that as needed based upon changes in incidence. But for now, that's our recommendation. And of course, anyone who is has a exposure, we're testing as well. So basically almost anybody and everybody who has a reason to test, we are testing, just not mass retesting of all healthcare workers. And that's it. That's my report for today.
Excellent. Thank you so much, Sam. We will now just get right into our main presentation today, and we want to make sure we have plenty of time not only for our presenters to present, but also to get a lot of questions in. As we know, we imagine there will be a lot today. Thanks for those of you already putting questions in. Please go ahead and continue to do that, and we will answer certain ones throughout the presentation and try to save as many as possible for the Q&A towards the end. This week, we're going to start something a little new also in the background. Helena is going to send out a survey. We're going to start basically trying to get more input from you all. And it's an anonymous survey if you want. All the questions are optional, and we'll start doing this every week. And the purpose is just to get more feedback from you to make sure we're tailoring grand rounds the best possible. We know we have a lot of people joining us not only within the Department of Medicine, but throughout the School of Medicine and the hospital. And we want to make sure the topics are as impactful as possible for you. We think today's will be, it's been a question we've been hearing a lot of what's going on community, and particularly over in East San Jose Regional Medical Center. And so we're looking forward to hearing more about that. Helena sent out that survey, and Talia will send out the links for the CME as well today. So with our presenters, Alex, I'll go ahead and let you put the slides up on while I'm introducing. We have two presenters. Our first one is Dr. Elsa Villarino. Dr. Villarino is the Assistant Health Officer and Tuberculosis Controller for our Santa Clara County Department. And so she's worked for the CDC for over 31 years, based in Atlanta, based in Mexico City. She practices in San Jose. And one thing I looked up on her profile, which I really loved, is she stated she states, "My objectives are to improve the health of the populations of Mexico, the United States, and the world." And if you look at her history, she really is doing that. Dr. Villarino, thank you for being with us. Along with her is Dr. Alex Studemeister, and I'd like to thank Dr. Upi Singh for recommending Dr. Studemeister as a presenter. When we were asking about where we can learn more about the county, she pointed out that Regional Medical Center in East San Jose was perhaps, and we'll learn more about this, the busiest hospital in regards to dealing with COVID since the outbreak. And Dr. Studemeister is a infectious disease specialist. He works not just at, he's not only serving the East San Jose, he's also various Santa Clara County Hospital, including O'Connor, Good Samaritan, El Camino, and of course, Regional. And he's also an adjunct clinical professor at Stanford. I wanted to, Dr. Dean Winslow emailed me, Alex, and you know, Dean was the former chair at Santa Clara Valley, and he sent a message to me. He asked me to just say thank you for being here today, and he wanted to that he's an open educator, a great clinician, and he's just really a great teacher of the fellows over the years. And he wanted to thank you for volunteering your time, and he's really excited amongst all of us to hear you and Elsa speak today. So thanks for joining us today, and I'll turn it over to you. I believe, Elsa, you're going to go first.
Yes, hello, good morning, and thank you again for the invitation. Can you hear me correctly, Harold?
Yes, perfect.
Yes, we're going to start just, thank you also to Alex for having invited me to join him. My part of the presentation is short. I'm going to be speaking about the epidemiology of COVID-19 in Santa Clara County from the first case that we recognize up to June the 10th of 2020. Then I'm going to pass over the presentation to Alex, who obviously has prepared a very detailed review of all the cases that have been diagnosed and managed in Regional Medical Center. And he's going to start by reminding us that they're still happening. The most recent one will be discussed, and then a study that he did by reviewing the charts and medical records of the patients that they have seen in this medical center for the last 3 months. And then finally, the conclusions and recommendations. So for myself, if we can go to the next one, the This is an epidemiologic curve of COVID-19 cases in the county of Santa Clara. They are part of our review of CalReady. They are all registered as cases in residents of Santa Clara County, with a few exceptions, which would be travelers. For example, at the beginning of the epidemic, we had a traveler that came from Wuhan, China, and was the second recognized case of COVID in our community, but she was visiting. The first recognized case in our community was a resident of San Jose that had traveled to China, and those are depicted on the slide in late January and the beginning of February. Then, as you all know, because it was all in the news, in the beginning of February, again, February the 6th and February 17th, two autopsy results came back from patients that had died on those days, and they were identified through the examination of the tissues to also have been deceased, and the cause of death was due to COVID-19 infection. So our epidemiology curve got shifted a little bit earlier than what the bulk of it is. We had that at the beginning, and then you can see in the epi curve also events of importance, such as when we began testing in the local public health department. On the 27th of February, we began identifying the community, what we call community-based COVID-19 cases. Then you can see when the school closures were issued, and then the shelter-in-place orders, and how it has definitely changed the epidemiologic curve, but also the fact that there is an epidemic within an epidemic. You can also see that in orange, there are the cases that are identified as happening either in staff or residents of long-term care facilities, specifically skilled nursing facilities, and those are in orange. If you can show the next one. This is our epidemiologic curve on deaths, again, divided between whether or not they occurred in a member of the community or is somebody who's institutionalized in a long-term care facility. As of June the 10th, there were 149 deaths recognized in Santa Clara County. There were a few more in the last few days. It happens one or two up to four every day, even as we speak. The next. This one is the case counts and the age-adjusted case rates by race ethnicity in the county of Santa Clara, meant to show the disparity that we have in the cases amongst our population. As you can see, Hispanic Latino population, even when adjusted by their age adjusted, is still an overrepresentation of the number of cases, severely impacted by many reasons. And the African American population that is very significant in other parts of our country and even other counties within the US, in San Jose and in Santa Clara, it's actually quite small. So the height of that bar adjusted for African Americans is a little bit misleading. But you can see that the case count and even the crude case rate that we're not showing here doesn't differ that much when you do age adjustment for those populations that we can have the information and age adjust. The next slide shows it in a very graphic form, how at the beginning of the epidemic, the Asian community was more highly impacted and got represented, as those are the bars in purple. But as we have progressed, the blue bars again size and importance, and those represent the Hispanic Latino population. And what I would have to say is that the Hispanic Latino were probably there as early as the Asian population, but they were even less accessible to health services that where I have identified the cases by testing or by hospitalization and diagnosis in a hospital. And you'll hear about that when you hear Alex's presentation. The next one is our positivity rate. That's how the percent of tests that are positive from tests that are done. It's important to see it in this manner because as testing capacity has increased in our county, of course, that could have given rise to identifying more cases. And but as you can tell, the test positivity came down as the number of tests increased as expected. But there is now, with the opening of the society and the shelter-in-place removals, there's an indication that the test positivity is going up. And this, if it had stayed stable or continued to go down, then we could be hopeful that the epidemic might continue to keep flat or go down. But in this case, there's early indication, and also in hospitalizations, that it's actually trending upwards. Finally, in my last slide, I'm just gonna share with you that in Santa Clara County Public Health Department, we are also beginning to use whole genome sequencing as a tool to investigate COVID-19 outbreaks. We are working together both with UCSF and Chan Zuckerberg Foundation in San Francisco, in that we sent to them the samples identified in our lab by the public health lab. One of the limitations we have is that now that testing is done at many different labs, even throughout the country, for the patients identified in Santa Clara County, we don't have a complete set of all the samples that we would like to sequence in order to understand what is the epidemiology of our outbreak of COVID-19, and also to study links. The first announcements that you heard this morning were saying that there's been little to no events of healthcare worker transmission in the healthcare setting, perhaps to their patients or to their co-workers. Those are beginning to become more evident. And the only way sometimes we can truly prove them is using an advanced tool that doesn't just rely on history like the traditional epidemiology does, but actually can look at the genome. And we also feel like by doing this type of extra analysis on all the samples in Santa Clara County, we are contributing to the global view of the evolution of the COVID-19 epidemic, because everything that is sequenced is posted in open repositories such as GSED and NCBI. And now I will turn it over to Alex, Dr. Studemeister, who is, I met as my colleague for doing tuberculosis control. A lot of patients come to this hospital that are also treated for tuberculosis, and now he has become the expert of treating for COVID-19 as well. If you could pass the next slide, and then the presenting capacity to Alex Errol.
Well, thanks so much. Really appreciate that presentation. I'd like to also thank Dr. Singh for inviting me over, and faculty staff present for being present and allowing me to present the cases that in our experience at Regional Medical Center. I'll start off with a vignette of a representative case. This is our latest case appearing in our hospital May 31st. She was a 58-year-old Hispanic woman presenting with GI symptoms, which can occur around 17% of the cases of COVID present with GI symptoms. And she did have quite significant nausea, diarrhea, fatigue for a short time, 3 days. She had no respiratory symptoms at all, no hypoxia, with normal chest x-ray shown there on the bottom left. And found with uncontrolled diabetes with hyperglycemia and positive COVID testing. She was quite disappointed that she tested positive because she spent a lot of energy and efforts to remain shut in with her daughter and son-in-law, who also were hospitalized on the same day at other hospitals. The son-in-law was quite ill. Apparently, he ended up in the ICU at a different hospital. Son-in-law was working construction and was exposed to a coworker who was recently ill. So patient had a lot of GI symptoms. She did not meet the criteria for remdesivir treatment initially until day 4, when she developed significant hypoxia and infiltrates, and we started her on remdesivir. She improved, but had quite slow improvement. Even after 2.5 weeks, she's still in the hospital with fatigue and other issues, but did not require intensive care admission. So I work at Regional Medical Center. This is a large hospital, comprehensive stroke center, level 2 trauma, 264 beds with 1,600 employees and a 34-bed intensive care unit. We have had the highest cases of COVID cases in Santa Clara County, as noted there on the chart on the right side. We represent the red line there, and compared to the other hospitals in Santa Clara County, we had the most admissions. And you can see there in the center graph the location of Regional Medical Center, which is at the crossroads of Highway 101 and 680 in East San Jose. And here's another representation of our cases admitted to all the hospitals in the county, shown by the blue line, and then regional medical center cases, which formed a large percentage of cases being admitted in the county between March 27th and June. So this brought up several questions which got me interested in pursuing this study further. Why so many cases at regional? Are we dealing with a epidemic that's random, scattered around the county, or are there hotspots and causing such a variety of presentations and so many cases? What are the factors affecting mortality figures in our hospital? We had a relatively elevated mortality rate, as you'll see. And finally, what are the implications for us physicians and public health practitioners? So the methods of our study is included here. You see it's a retrospective manual chart review done by me, including all adults presenting to the emergency room who tested positive for COVID-19 within 14 days of ED visit or post-hospitalization. Testing was done by nasopharyngeal swabs and sent to the respective laboratories as noted. The time period is between our first case, which presented in February 28, until May 31st, a 3-month period. And this involved an actual manual chart review done by me. Our cases were taken care of mostly by our fantastic hospitalist team. These are very dedicated physicians, offer 24/7 services, and work very well within themselves and with all the physicians and nurses and other staff. Intensive care cases were also managed by a very dedicated intensivist team with 24/7 services. So this is very important to take care of these patients, to have a good cohesive team and highly dedicated to care of patients. Of course, we had consultations availability from all the specialties, and including palliative care teams and ancillary services. All our ICU cases were also followed daily by the cardiothoracic team, since we are a ECMO center. So this is the consort flow diagram, starting with the 210 cases coming into the ED at Regional Medical Center over the 3-month period, diagnosed with COVID-19. From those, 33 were excluded, as 29 were not hospitalized, and 4 unfortunately expired in the ED. This number reflects the severity of cases that we present, and also the other socioeconomic factors and other issues that may have influenced our mortality figures. The 4 expired in ED reflect, for example, lack of access to healthcare. For example, one patient presented with acute asthma exacerbation, could not find her inhalers called EMS, and unfortunately did not survive, and she tested positive for COVID. So from our 177 admitted patients, we had 133 coming in from the community and 44 from the nursing homes. And you see there, the 50% of cases coming from community required ICU. That's a large figure. Most series show that around 5 to 10% of patients being admitted require intensive care unit. So we're already starting with a apparently quite ill set of patients to be studied. So this is the epidemic curve. You see there, starting from February 28th, our first case, going all the way to May 31st. And you see the blue lines are patients coming in from the community, the orange from the nursing home. And you see a rapid rise, a rapid upward slope initially, a tremendous number of cases. We're getting 10 to 12 cases in some days a day in the ED. And then a rapid fall off in trickling of cases late April, early May. As Elsa mentioned, we experienced a second epidemic curve, as noted by the orange lines from outbreaks occurring in the nursing homes. And you see there the date of the shelter-in-place order, March 17, 18, in Santa Clara County. So this is a curve looking at the ages and the number of cases respective to each decade. You see most of the cases were in the ages from 40s to 70s. Mortality figures are predominantly over age 70, and we had some very quite elderly folks over age 90, and their mortality rate was quite high, about 50% mortality rate, unfortunately. Each death is a tragic situation. It involves loved ones and family members, and of course, all the caregivers involved in their care were affected quite deeply by each death. So this is, I'm going to talk about now the metrics of our study group, our cohort of 177 admitted cases. Their median age was 61, as you see, and like Elsa had mentioned, with the predominance of Hispanic persons being in that group, 68%. There's, as far as where they got the infection, was not identified in about 60%. 17% of cases, I was able to identify their exposure as far as family member being also having COVID or acquisition of the infection in the workplace. And the intensive care unit cases, 66 required ICU care with an intubation rate of 32%. So not all patients going into the ICU required ICU. We were able to salvage some patients and keep them from getting intubated by applying high flow oxygen in prone position. The mortality figures are noted there, affected by the nursing home cases, rising the mortality figure up to 24% as noted. But if you exclude those nursing home cases, our mortality figure was 11%. So looking again at our hospitalized cases, 177. As far as their race, ethnicity, there was a predominance of Hispanic persons, 68%, compared to the county statistic, which is 26%. So an overrepresentation of Hispanic persons in our hospitalized patients, most of whom were quite ill. Unfortunately, the deaths were 42 compared to 141 in the county by that date, by May 31st. So I was able to look at the socioeconomic demographics of 93 cases who were under age 65 coming in from the community. You'll see their employment status was determined to be mainly construction in 11 cases, or 12%, food services, factory work, office work, retail, and multiple other essential jobs. So these are all essential jobs, persons that didn't have the luxury to stay home and remain isolated. Possibly they didn't have availability of protective equipment also. And so 3 of them were medically disabled, and a large percentage were uninsured or had medical status. So another issue I looked at is the zip codes of origin, where they lived. You can see there on the left side, Regional Medical Center that is located in East San Jose there, noted by the red star. And most of our cases came in from the surrounding zip codes. The darker green are the highest number of cases coming from that particular zip code. Many 95116, 95127, 95122, all the different 6 zip codes supplied most of our cases. And these are all in the East San Jose area. What is striking is that if you look at the pictures on the right, the density of population, these zip codes are located representing high density areas and of low socioeconomic status, as noted in the lower map. So we're having most of our cases coming in from high density areas of East San Jose, from low socioeconomic neighborhoods. So now I'll talk about the clinical presentations of our cases. 78% presented with a classical triad of fever, cough, dyspnea. And as you can see there, patients presented with other symptoms, chest pain, fatigue, headache, GI symptoms, or altered level of consciousness. This points to the clinicians having an open mind and taking a diagnostic timeout. Whenever you see a patient coming in with not the classical symptoms, take a time out diagnostically and think of COVID or other possible diagnoses in your patient presenting with these symptoms. As far as the median length of symptoms before arrival to the ED, most patients presented around with 5 or 6 days of illness. So you can see there, fever, cough, dyspnea was the most common presentation. But some patients even came in after 21 days of symptoms. Chest pain, diarrhea, fatigue. This points to this illness as being not an abrupt onset illness where patients get suddenly ill and need immediate hospitalization. A lot of our cases were symptomatic for some time before finally coming to the ED. The other point here is that our cases point to there being a narrow window of treatment opportunity. Patients are coming in, already 5, 7, up to 21 days of illness, past the viral peak, and very soon thereafter, usually around the 7-day post-hospitalization, going into severe illness. For this virus, the mean incubation in reviewing the literature was generally 4 to 5 days. The viral load generally reaches a peak in about 5 to 6 days, compared to the SARS virus, which peaks later, around 10 days. And the progression to ARDS in studies reviewed usually occurs around 8 to 9 days. But you'll see there, patients are coming in already 7 days ill, 10 days ill, 21 days ill, pointing to there being a very narrow window of opportunity. We really need to attack this problem pre-hospitalization. By the time patients are hospitalized, it may be too late in some cases, in many cases, to offer effective antiviral therapy. We had cases with unusual presentations, pointing again to always taking a diagnostic timeout when you're seeing a patient. Multiple patients present with just Alto liver consciousness, disorientation after motor vehicle accident, an obtunded person from a nursing home without fever, homeless person coming in, found down on the street. We had a 25-year-old otherwise healthy person coming with pulmonary embolus. And then stroke picture was not unusual in some cases, presenting with acute thalamic hemorrhage, for example. And a patient developing a postoperative fever, a 24-year-old man that was stabbed in a party, had surgery for his pneumothorax and developed a postoperative fever. An 86-year-old nursing home resident diagnosed with COVID after hip fracture surgery. So again, patients can present without fever, the clinical triad. So, and to look at the metrics of our nursing home patients, this shows 44 cases coming in from the nursing homes related to outbreaks occurring in the nursing homes in Santa Clara County. They're older with a median age of 75, and some of them required ICU with intubation as noted. Some patients required ICU on arrival to the ED, and unfortunately, they had high mortality rates. Why is that? Well, we already know, they're coming in with an older age and multiple comorbidities. These you can see in this graph here that most of our cases from the nursing home came from one particular nursing home, 74%, and there are 3 other nursing homes which contributed the rest of cases associated with an outbreak or of COVID in the respective nursing homes. Atypical presentation was not unusual, no fever, Alto liver consciousness, falling, and stroke picture. So as far as our nursing home patients, what distinguished them from our cases from the community is shown here. They're older with a median age of 75. They had more than one comorbidity with a significant factor there of 71% had more than one comorbidity, and high mortality as we discussed. So now I'll talk about our intensive care patients. As you can see here, this is a commonly published graphic showing the early phase of infection with a rapid rise in viral load, followed by the inflammatory phase. In taking care of all our ICU patients, we saw that there should probably be a 4th stage. Patients with prolonged mechanical ventilation, so past 21 days on a ventilator, had a rocky course. They had respiratory failure, pneumonia, and other complications as noted. Encephalopathy was quite common, and tissue necrosis problems. And of course, we don't know yet what the long-term outlook is for these patients that go on post-discharge to a stage 5 possibly. What is their ultimate outcome is not defined yet. And there's probably a virological effects. It's not only the host factors, but also viral factors. As we know, this virus causes a cytopathic infection involving pyroptosis, where there's caspase enzyme activation leading to osmotic lysis of the cells and release of inflammatory cytokines, interleukin-1b, interleukin-18, other factors which cause a cell death associated with inflammation. So looking at our intensive care unit, you can see here, post-admission, some patients before going to the ICU were actually hospitalized even up to 22 days, remaining without indications for ICU admission. Most of them had 7 days of symptoms before ICU admission. But the usual course was developing dyspnea and hypoxia. Those are two main findings pre-ICU admission. Once patients developed dyspnea, hypoxia, once they required high flow oxygen, we admitted them to the ICU on high flow oxygen with prone ventilation. 4 patients were intubated on arrival to the ED. And we had several patients who were otherwise healthy without comorbidities, who had a severe course and required intubation and ICU care. So not predictable. Some cases were not predictable, and I'm sure this is seen in other medical centers. And as stated, we had 15 cases who required prolonged mechanical ventilation. Their clinical courses were always rocky with fever, sepsis, pictures, shock, and encephalopathy. They had prolonged swab positivities with lots of discussion about what the meaning was and trying to get patients to the nursing homes with some difficulties because of the COVID positivity. 6 required tracheostomy. And all this points to we're all trained, the hospitalists and intensive care units, physicians are all trained to speak right immediately with the family members and the patients as far as their goals of care and establish early on their advanced directives and what they would want to happen to them should they end up in the ICU. As their prognosis generally is not good, and the patients, this is seen at other medical centers, this becomes a prolonged illness, unlike other infections. So comparing the ICU cases with the medical ward patients, they're older. You can see their median age is 68, and they had significantly more diabetes mellitus and obesity. And could there be a biochemical corollary, physiologic corollary, explaining why diabetes or obesity is associated with more severe disease? That's being studied. Obesity or BMI has to do with fat, body mass, adipose tissue, the amount of adipose tissue in the body, and could that be somehow related to a hyperimmune inflammatory response? With diabetes mellitus, similarly, there may be metabolic issues, biochemical issues leading to a hyperimmune response and cytokine release syndrome. And then the older age, that's why that's a factor leading to more severe disease. Is biochemically is not quite well known. Could be related to enhancements of antibody response to secondary to previous exposure to community coronavirus. So these are older folks that have been exposed to community coronavirus, and could there be antibody enhancement issues like you see in dengue in these older patients, leading to more severe disease. So the next few slides, we talk about the clinical picture in the ICU. We didn't have a major problems with MDRO or multiple drug resistant organisms. We have a strong antibiotic stewardship program there and dedicated pharmacists reviewing each case in the ICU and going on rounds with the intensivists. The main documented infections were pneumonia, septicemia as noted, with a couple cases of fungemia, and then CMV reactivation in the renal transplant patient. We had problems with thrombosis, has been described in other centers, with an overall 6% rate of thrombosis, involving even arteriovenous fistula and clotting of the vascular line in the renal replacement therapy. As far as stroke events, overall rate was 5% compared to in the influenza, the rate published in the literature is about 8.5% of influenza cases associated with neurological complications. A couple of cases came in with acute ischemic stroke from a home or nursing home. And we had one case down below with what appeared to be acute hemorrhagic necrotizing encephalopathy, which is seen in pediatric cases following viral illnesses such as influenza, thought to be related to an intracranial cytokine overresponse and associated with thalamic lesions and bilateral cerebral lesions with internal hemorrhage. And this has been published before in one case involving COVID infection. So finally, comparing our cases with the cohort presented in this forum several weeks ago, you'll see here our cases on the left side and the Stanford cohort of hospitalized patients. Our cases have more severe disease, apparently, as shown by higher rates of intensive care admission and needing a mechanical ventilation. All our cases were given ventilation to protective ventilation measures, such as low tidal volumes and other measures, prone ventilation, for example, to prevent lung damage. As you see there, prolonged intubation was required in about 8% of cases. And we have the complications listed there, similar as in Stanford, with predominance of encephalopathy in our case, manifest by agitation and dysynchrony with ventilator. Quite problematic and with causing difficulties in extubation, very often requiring tracheostomy. As far as our mortality figures, you see there, those patients that expired, did not survive, were of older age, had more comorbidities, and came from nursing homes. And finally, like it was done at the Stanford presentation a few weeks ago, I compared our cohort with the other published cohorts from the West Coast. And the first group there is from Seattle. These patients were recently published in the CID. And they also had quite a large number of comorbidities there, 93% actually, with a lot of their patients coming in from the nursing homes or assisted living facilities, like our case, with a relatively higher mortality as noted, with our mortality being high as a result of probably a large percentage of patients coming from the nursing home. Excluding those, our mortality was 11%. The Kaiser group also presented, published their cases there in Northern California, and with a mortality of 17%. And then you see there the Stanford group cohort. So what are the conclusions and implications for physicians? When I see a patient with COVID in front of me, I think about stratifying the risk in that patient, especially if the patient's middle age or older, with high risk conditions as noted. That's a strong consideration there. And also I need to consider socioeconomic factors, which may have also affect risk and prognosis in the patient in front of you. As far as the comorbidities and socioeconomic factors we presented here, their unequal impact, for example, on the Hispanic population and the nursing home residents, which had high risk of severe disease and hospitalization. And finally, the study our study shows the need for pre-hospital interventions. For example, pre-hospitalization treatment and early diagnosis is key before, like I said, before the patients present to the hospital emergency room they are very often already quite ill, past the viral load peak. So early intervention, therapeutic intervention early on seems to me the key here to control virologically this process here. All right, thank you very much.
Alex, thank you. Elsa, thank you for that really informative presentation. It just motivates me to want to say thank you. We've been hearing as healthcare providers, thank you for your care. I want to say to you guys, thank you for the care you guys have been providing, given the load that you guys have been dealing with since the onset of this. We have no surprise, lots of questions for you, both you and Elsa. So I want to get right into that. And Elsa, if you'd like, your video is on, and you can turn your mic on when you feel appropriate. So a few questions here. And Alex, if you want to unshare your screen, unless there's some slides you want to share, you're welcome to do so. But I'll just get into the first question. Can you please, and this has been a common question we get often, and with you and perhaps with Elsa with us as well, thoughts on the concern for a possible surge. Can you please discuss the surge that will happen? Does it feel like no one is discussing what to expect? Is it safe to go out? What do you advise from that perspective? Question, probably one of the most difficult ones. Any comments on what your thoughts on the worry of the next surge?
Well, the next surge is expected. I can see it coming already, and that's why it's so important to have studies such as Dr. Singh's study of treatment, diagnosing and treatment early on before hospitalization. But it's probably coming, just like in H1N1, there was a surge in the fall after opening up of the schools. The school children were involved in promoting a second surge in the H1N1 influenza pandemic. And the socioeconomic factors are not going away. We have still the issue of COVID hot zip codes in the area there, East San Jose. There is a testing availability, but as far as early intervention, early treatment, in those areas involving the population, the Hispanic population, especially in the hot COVID zip codes, is lacking, as I see it. There's an avenue of growth there, potential growth, and potential patient material for any therapeutic interventions early on.
Great, thank you. Elsa, any thoughts as well?
Yes. The county of San Jose has increased the number of testing sites tremendously and has focused on putting the testing sites on areas where we recognize there's the most need. In the southern part of the county as well, Gilroy, Morgan Hills, that area, there are several facilities. They're free for the public. I think I agree with Alex completely. No one believes, unfortunately, that we won't see a second wave. So what we are focusing on is to try to make the second wave not be as deadly as the first wave. Perhaps, again, community education, we're presenting to the hospital early, knowing that no matter what your insurance status or lack of, you will still get care, and that it won't be that you will go into the hospital and never again be able to talk to your families or say goodbye. Hopefully you'll go into the hospital to get better and to survive this terrible epidemic.
Thank you. That's great answers. This next question is coming from one of our own ICU doctors. Angela Rogers asks, should there have been more of a county response? For example, transferring patients from highly impacted ICUs like regional medical center to a less impacted ICU. Should we do things differently in the coming weeks?
Well, I'll answer briefly and then Alex. Actually, the county response was tremendous. This census of hospital beds and ICU beds and ventilators associated to the ICU that started really at the response time very early. It was never, never came to any critical condition where transfers would be necessary. Transfers were actually into RMC. Alex would say a patient from El Camino Hospital went to RMC for ECMO, for example. Sometimes it's not necessarily the census of the bed, but where the capacities are. And Alex, do you want to add to this response?
Yeah, that ICU bed was not a problem. At our peak, 80% of our ICU beds were filled with COVID patients. At one time, we had up to 67 cases in the hospital itself. But availability of ICU beds was not a great problem. There was some, at one point there was manpower issue, and we had help from Good Samaritan Hospital on the west side, and we did transfer several cases over to them because of hospitalist manpower issues. And that worked out really well. We had a good relationship with the sister hospital on the west side to accept some cases when we felt overloaded.
Gotcha. Thank you. On the next two questions, they're very similar. What is happening with contact tracing, and does the county have any insights into contact tracing, how infections occur? That's another kind of tough question.
Contact tracing is the hottest topic now. Obviously, contact traces was done very well also at the start of the epidemic, and it does give you a lot of insight into how so there's the expected, of course, household transmission, but now we are beginning to investigate clusters in other, for example, workplace transmission, not healthcare, construction sites and fish packing plants and other areas that are not the traditional places that public health has normally gone into to conducting investigations. And also, most importantly, is that what control methods can you help implement? When do you ask them to shut down an activity at the cost of, with the economic and other impact that it has? How does it affect the families back at the home? Even families, Alex had a good example, that are sheltered in place. They think the one member of the family that goes in and out to do essential work returns home, and it's very difficult to self-isolate. The recommendation of self-isolation, everybody have it in their own bedroom, their own bathroom, is just not the socioeconomic reality of most people, even in our well-to-do county. It's really a minority.
Good. So next question. If you've been to the east side of San Jose, specifically Story Road, there are a ton of homeless people lined up. I know this well. I'm from San Jose. Such the fact, can you explain the effects of spread to others that cannot quarantine? I just want to mention, you and Kim mentioned Cheryl Ho is a great future speaker. Actually, Cheryl is on my next list of persons to email and schedule. So thanks for pointing that out, Ewan. But any comments from either of you regarding this issue that I'm sure you're very well aware of?
The county also has done a tremendous amount of work and has provided housing for many of the people that live in campus, and has investigated any outbreak or seemingly an outbreak, either in a volunteer of the shelter or a shelter home resident. We haven't found, and we have been lucky that there has been large transmission events. We have been able to, when a hospital calls the county and saying, we're going to discharge a patient, and the patient is known to have unstable or no housing, then the county provides the shelter. In So in Santa Clara County, it has not been a foci of more transmission, and it has been well attended to.
Ronald Gibbs asks, can you please explain the apparent lack of spread from the first two cases in late January, early February? Is it the spread or the relative test?
I think you were breaking up
Sure,
a little
sorry.
bit. We
No
are
problem.
actually, I don't have the complete answer to that. So the two early cases that were travelers, there's not a lot of surprise that they didn't cause a lot of spread, because we actually, the county had very strict criteria for isolating them, and they were also part of very small family units, and they developed disease almost immediately upon their arrival. One was sick, having symptoms when the plane landed, the other one the day after. They visited healthcare facilities around San Jose and Santa Clara, but there was no transmission to healthcare personnel or to other people at the facility at the same time. And then they were able to self-isolate and didn't go back to work until they were repeatedly tested. Their gene sequences are already available, and they are, because CDC was doing the testing then, and all the specimens that can be sequenced that are sufficient quality are done immediately by the CDC and posted online. So they were definitely associated to the Asian strains. It's imported infection that didn't go anywhere or wider. But the continuation to that question would be, well, which strains or lineages of this virus did create the hotspot and did become very transmissible and widespread and created our epidemic? And we don't know exactly the answer to that. We're trying to elucidate it, and our main limitation is the small number of specimens that we have to analyze.
I'm not surprising that the spread is not an issue in those cases. The main factors involved with spreading are these socioeconomic factors, employment status, healthcare access, residential segregation, people living in high density zones, and finally, economic inequality. Those are the four factors that play a role as far as spread and number of cases that we saw at regional.
Yeah, couldn't agree with you more, both of your comments. And to that effect, we'll continue to have this be a big focus of our topics moving forward. We'll just hang out for a couple more minutes if that's okay with you both. We've had so many questions, and we will, if it's okay as well, I'll send a list of these questions to you after, so we can, if you'd like to answer any more, we send a follow-up email after every grand rounds with questions and answers. One question here is an important one. Is there any data on undocumented people that might not be coming in for treatment due to fear? We observed some of this up here. Can you explain maybe some of these numbers are higher in the area due to income disparity? You were just talking about, Alex, multifamily living in a home. Questions along those lines, people not coming in due to fear. Is that something you've seen or been able to surmise?
Not in my review, and just in talking with the patients. I'm fluent in Spanish, so I get told the background of some cases, and there's some level of fear of coming into the hospital and being identified as COVID positive with regards to their work status. A lot of these persons coming in, are highly dependent on work and employment just to survive, to put food on the table, and so there is sometimes a tendency not to seek help because of their social economic employment issues. But more study needs to be done with regards to the question.
I would agree. I don't think that the legal status of their residency is so much as the consequences of being told they need to quarantine or isolate, and what's going to happen to the rest of the family if they are the main breadwinners. But as you know, at least in the county hospitals and in all the hospitals, when there's an emergency that needs to be admitted, the having insurance or not, or the residency status, is not something that is considered. I think the fear of the population is more the fear of is also the fear of the disease and of the consequences of the disease.
Guys, thank you so much. It's 9:06 now, so be respectful of yours and everybody's time. I think we'll stop here. There are a lot more questions I was hoping to hear too, so I'll email out to you guys, and we'll follow up with an email to everybody with the answers. Dr. Studemeister, Dr. Villarino, thank you again for the great presentations, for taking care of the people that you take care of, including my family who live just 3 miles. So thank you so much for everything you do. And again, thanks for joining us today. Thanks to everybody and our panelists, as always, for being with us. And please keep us updated on your feedback through the surveys and the comments we've been getting. Thank you so much. And we'll go ahead and end it there. Okay, bye-bye.
Thank you.
Thank you.